what I'm going to try and do is tell you where PSA has gone from my perspective in the years of the IPCU has met over 25 years. Analyte that has revolutionized this disease and certainly almost caused a revolution. So I'm going to do this, and I'm sure I'm going to miss some of your favorite papers. I'm going to take the most important paper that I see through the years since 1991. But we have to begin at the beginning, and a lot of this work it was started at Roswell Park under the tutelage of Gerald Murphy, seen here. And the important early work included albums identifying of a protein that ultimately was shown on 2D gel and eventually that was PSA. Hara described it as gametal seminal protein. Lee and Belling were able to purify this protein from the seminal plasma. Wang purified it from prostate, which is really a seminal event, no pun intended, in the development of this. Naji and associates were the first to describe the relationship of PSA to prostate cancer. We heard a lot about Hans Lilius' very important work that really begins in '85 when he characterized the different subsets. Then in 1986, Hybridtech and Myrtle were the first to develop a commercially available assay, not for screening, but for monitoring the disease. And later that year, FDA approval was granted. I owe very much to these two people. Dr. Stamey was my mentor, guide, oftentimes adversary as we went through this process. But in 1987, he published, at that point, certainly the most important paper on PSA in the New England Journal, where he looked at very carefully its role in prostate cancer. Again, no mention and no consideration that it would ever be useful as a diagnostic or screening test. One of my old bosses, Paul Lane, contributed greatly in this arena. He was able to characterize the fall of PSA after successful radical prostatectomy, its most definitive use at that time. Very, very important. I could put Crawford on every one of these slides for some aspect, but I'll highlight what he really did with Prostate Cancer Awareness Week and the development of the PCEC, because he and his team brought the whole issue of prostate cancer awareness to a forefront and coupled that certainly with the development of PSA. In 1989, I was skeptical. I had left Stanford. Stamey kept saying it'll never be used for early detection or screening. Nagel and I published a paper when I was at the University of Arizona that said it wasn't, if you only had BPH or BPH with chronic inflammation, you didn't have an elevated PSA when you underwent simple prostatectomy. There was always some other perturbation. And that was the inkling that I had that said maybe everyone, Walsh, Stamey, everyone who said this would never work for early detection might be wrong. Bill Catalona beat us to press by a few months, but we both did very similar studies, designed separately, both funded by Hybridtech. But as it's not often remembered, my hypothesis going into this was it would not work. But amazingly, our two papers showed essentially exactly the same results, detection rates of just over 3 and positive predictive values of 1/3, which was amazing when you remember at that point we were only doing 6 systematic sector cores. At the conclusion of our first publication on this, I wrote that what you see in red, which I'll let you read, but I worried, partly because my hypothesis was not going to work, but I was concerned that we were going to over-detect that disease. And I guess we've seen it. Now, once we had PSA, we wanted to make it better. And everyone tried to improve on PSA, and there was a lot of work. Joe Osterling was very instrumental in developing age-specific PSA. Bruce Dalkin at Arizona the same year published very similar results. And it was obvious. The older you were, your PSA was going up for a lot of reasons. They decided to use different thresholds at different ages. But the problem they failed to recognize was that prostate cancer also was going up. And if you corrected for age by PSA, you missed more cancers in the patients that were most likely to have it. Bal Carter and the group at at the Brady Hopkins did really a very important study with the Baltimore Longitudinal Aging cohort that taught us that the change in PSA over time was extremely helpful. It also reminded us why we took calculus in college. We did the first study at Washington now, and then Seminole in Europe showed the cacophony of results one could get when you measured the same serum with different assays. We had a big problem in the United States. Ultimately, we corrected it. The problem in Europe was disastrous, where you could get fourfold differences in PSA levels just by looking at a different assay. Alan Parton, of course, is here. You can see the concentration as he's playing a beer game here, but Parton contributed so much over the years to this analyte. I think ultimately, and this is the topic of his presentation here, it was the combination of PSA clinical stage and Gleason score, the so-called Parton tables, that really made us think we need to integrate all these. Following the work of Lila, Catalona did a lot of work and ran the international study on the free PSA, showing free to total PSA ratio was very important and was discriminated cancer from not much better than total PSA. We were able to show the same results with complex PSA with only a single analyte, and then Slawin and Milojewicz looked at BPSA, which you'll hear more about as we move forward. Things got a little topsy-turvy, and we entered very troubled seas with a paper by Etzioni in 2002, who first raised the siren call that we may have a problem with overdetection of prostate cancer. And the rest we know. Isfer J. Schalken and our good friends Franz de Bruyne did a lot of work telling us the urine could be another good analyte and developed the then called UPM3, now we know it as PCA3. Of course, we all know the great work of Thompson in the prostate cancer prevention trial, and one of the most important results out of that trial showed that there was a lot of cancer in men who had PSA less than 4. Grosskopf was able to add the very important instrumentation, and all the manufacturers in the audience, you've got to get a test that you can run on instruments in the modern era. And our president kind of alluded to some of this in his talk. We've got to move in this direction. But he made a reliable assay for PSA that could be instrumented. My old partner, Bill Ellis, taught us about the ultrasensitive PSA for monitoring after radical prostatectomy, and it was a harbinger of early evidence of recurrence. Whether it really makes a clinical sense remains unknown. 2009, a clearly important year because 2 seminal papers were published back-to-back, New England Journal. The ERSPC study, PSA screening works in Europe, particularly as you see in Sweden, and our good friend Jerry Andriel, the PLCO, David, very instrumental in this study, again, showing it didn't change survival. Controversy. Lots of studies are controversial, as we'll see. The Hugeson study is the best part, I think, of the European trial. It was published separately. That has the biggest effect, but it's a very disparate, different kind of population in Sweden, where there still is the highest prostate cancer mortality in the world. And whether these studies can really be extrapolated into a heavily screened U.S. population remains to be seen. Well, we kept trying to make PSA better. Again, Bill Catalona with the PHI test, Prostate Health Index. You can see clear improvement over PSA in black in the receiver operating curve. More calculus, again, was a problem. 2012, an important year in my life, we published finally the pivot results. You know the controversy associated with this study. It didn't improve all-cause or disease-specific mortality, but since we're talking to PSA, it did eloquently, I think, show that if all you knew about a man was he had cancer and the PSA was greater than 10, he did accrue a significant benefit both in disease-specific and overall mortality if he had a radical prostatectomy. So again, PSA came back. Well, later that year, we got the D from U.S. Preventive Task Force, a crazy grade, a crazy analysis, et cetera, but we've lived with it ever since. Correct. Last year published on the OPCO, the 4K score came out of Scardino and Lilius, and a very important improvement in adding dramatic overall performance is shown in the RLC curve when you look at both free total and HK2 and put it into a very sophisticated algorithm to do that. I will give you my slight perspective of where I think we're going in the next 25 years. This quote from Einstein teaches us a lot, and I think those of us that are students of this disease always need to remember this. But I think here's where what I think will happen in 2015 and beyond. I think we're going to continue, I hope we're going to continue to be able to test men for prostate cancer, probably initially with PSA, but I think, and we're seeing it now, we're going to do rational testings. The VA, which was testing 85-year-olds in congestive failure, has made amazing strides because of a very good integrated electronic health care network of not testing men who shouldn't be tested. And we need to extrapolate that to all testing. I think we're going to do more assessment early on in young men with PSA and potentially with genetic markers that will identify a cohort of men that need more vigorous screening or early detection programs and people that probably don't need to be tested after initial testing. We'll personalize the follow-up as we get more sophisticated, looking at things like velocity and change. But we're going to move away from serial annual testing, repeat biopsy, and everything else because it's crazy the way we're applying it. There will be more specific assays. I think the PHI test and the 4K test certainly show good promise. Scott mentioned the tremendous changes we're seeing in Gleason and the use of the molecular testing once prostate cancer has been diagnosed. And I think we're going to move more and more into the future with rational therapy because ultimately our goal has to be to identify the right person with prostate cancer and give the right treatment to that person at the right time.